Top Med Talk.
Welcome to Top Med Talk. I am Desiree, Chappell, host of the Roundtable on Top Med Talk, and we are here at the American Society for Enhanced Recovery in Washington, D.C. for the annual meeting. I am joined today by some very special guests, one that we have met before in the past, and it was at an ACER meeting, and we're here back again, Liz Pratt.
Yes.
Liz, thank you so much for joining us on Top Med Talk.
Thanks for having me.
Yeah.
This is really exciting.
Good. You said you listened to Top Med Talk.
I sure do.
I told her, I was like, I recognize your face and I recognize your name from social media because you like a lot of our stuff. So thank you so much for listening.
Thanks for having us, and thanks for offering that service for free. That's a way for me to connect and stay abreast of things when I'm back at work.
Yeah. So what do you do? What do you do, Liz?
So I'm the Director for Enhanced Surgical Recovery at Barnes Jewish Hospital in St. Louis, Missouri.
Very, very good. So you're in the trenches.
I am. Thankfully, I have wonderful colleagues across multiple specialties that make it much easier and enjoyable each day, because it's a daily effort to really help change culture around surgical recovery.
Yeah, absolutely. And anybody that's been in it knows
Yes.
it's not easy, but you know what? It's rewarding
Absolutely.
in the end, and we're all in it for the same reason, to improve
for the
outcomes
patient.
of things. That's right, absolutely. So you said you work with your team.
Yes.
And you have some colleagues here that came to the meeting with you. Can you introduce them?
Yeah, Rachel Wolfe is our perioperative clinical pharmacist, and she had a phenomenal poster with her colleague April Smith from Creighton University. And without the pharmacists, we would not have the level of knowledge, expertise around safe management of medications across the continuum. So they are an essential team member.
Oh, that's amazing. April, thank you so much for joining us. Mm-hmm. So on Top Med Talk and just in the enhanced recovery world, everywhere you go, you see surgeons, anesthesiologists, nurses, but a lot of these meetings, the larger part of the team is missing, and pharmacists are a huge part of that. And I mean, everywhere I go and lecture and talk about enhanced recovery, they're like, how do we get pharmacy on board? What do we need to do? It's very, very siloed still, I think, when it comes to pharmacy. So, Rachel, I want to start with you. What has your experience been in the world of working so closely with a specific quality improvement program? How's that gone for you?
Well, very well. I mean, for working with Barnes Jewish Hospital, we're very collaborative, but at the same time, looking nationwide, the presence of pharmacy within these programs is rather insufficient currently. Yeah. However, we do have some leading organizations that are out there that do have pharmacists intimately involved. However, we still need more. We need more pharmacists to I guess we just need more awareness of the need for pharmacy within this protocol. Because, I mean, as we have on our poster, with the colorectal, there are new guidelines that they actually published looking at all the elements that are involved in ERAS pathways. And essentially, out of those, there's pharmacotherapy within several of them. Yeah. Actually, over half of over 50% of those have pharmacotherapy involved in them. So, and as we expand with this, prehabilitation and pre-optimization, there's even more opportunities for a pharmacist to be involved. So, there's endless opportunities currently, and we're just touching the water right now. And so I think there's a lot more to do. A lot more awareness needs to be brought into the need for a pharmacist. And we're with the American College of Clinical Pharmacy, and we're actually trying to bring that awareness and publish out there about the need.
Well, I was just going to ask that. So within your national organization and professional organizations, how much are they really starting to talk about enhanced recovery? Or are they talking about enhanced recovery at all? Or do you feel like they're starting? Where are you guys on the spectrum?
I feel like even amongst ourselves, the American College of Clinical Pharmacy, like Rachel mentioned, which is how we met actually and started to collaborate, we just 2-3 years ago formed a perioperative medicine group of pharmacists. So we just got ourselves together, to let alone get that message then out to other providers. So that's why we're working on this big, large-scale publication that is going to be very comprehensive, listing out the roles of the pharmacists in all phases of care across the surgical journey. And it's a very collaborative project. We have about 10 authors, I think, from various institutions around the country.
Fantastic. And is that something you're going to be publishing in your own specific journal, or where are you hoping to put that out to?
So we're essentially, we were going several actually journals. It's probably going to be a multi-part.
Perfect.
Because
an international surgery journal. We thought about that. Mm-hmm. And then we ultimately did decide to go with our own. The American College of Clinical Pharmacy has their own journal, and they were willing to work with us on the multiple publication piece. And I think that was the hard part in going to a larger journal was they weren't necessarily interested in the breadth of the document, was huge. So we were able to break it up for the American College of Clinical Pharmacy standards.
Yeah, you should consider there's the Perioperative Medicine Journal, which is an online open source journal, as well as A&A, Anesthesia and Analgesia, which I believe they co-publish for their perioperative medicine articles, don't they?
Yeah, I actually thought about that today. In one of the sessions, they talked about how POCI really is actually being sponsored by ANA, and maybe that might be kind of part of where we actually tried to bring some stuff from there. But yeah, we just started with the Journal of the American College of Clinical Pharmacy to then just bring out the concept, and then as we break out more pharmacotherapeutic recommendations, kind of targeting specific journals, whether it is colorectal versus bariatric, and just that's kind of the vision we have currently, but that's still all to come.
That's good that you're even thinking about it. I mean, it's so important. So tell me about your poster.
So the poster just really is to highlight the role of the perioperative clinical pharmacy specialist within the surgical continuum of care. So it just highlights what we can do in the pre-op phase as well as the intra-op phase, and then bringing it down to the post-op phase and even the discharge planning, just pretty much the entire surgical continuum of care. And it just really highlights everything, as I mentioned a little bit earlier, just how we can be involved in developing and implementing the multi-modal analgesia regimens, PONV prophylaxis regimens. We can help develop realistic expectations in the patients related to patient counseling. We can provide feedback to clinicians on post-operative analgesia prescribing, education. There's just like an endless number of things that a pharmacist can do. And I know I talked a lot about analgesia, but there's fluid management, electrolyte management, anemia management. There's all those types of things. They all involve pharmacotherapeutic agents, so we can provide recommendations, look at the literature, and not every surgical specialty is the same. So it takes a lot of diving into the literature, understanding what's being published, what is actually beneficial versus what's not, and then also resource management related to, do we spend the extra money on this?
Yes.
Will we actually get the value and the patient outcomes that we want? So those are all the things that I think a pharmacist can add to the team to really develop and help implement develop your ERAS pathway, then implement the pathway, because I think a lot of us are interested in lean and change management, and we're able to do that because we are constantly. We talked actually just the other day how we are pretty much the continuity of the team. Yes. The residents change, the attendings change, the nurses change, but the pharmacist is that one single person that's consistently there with the surgical care of patients. And then also we love data and we love research. So we like to, see if what we implemented, is it actually making impact, and is it the positive impact? What do we need to tweak and change related to our pathways? Because we know we're not going to get them right the first time. So then that's another role that we can do. And I think we're well equipped and adept to do that.
Yeah, I would agree. And being the clinical pharmacist on a surgical floor, the continuity of care is big because I'm sitting in the same spot every day. The surgeon will come by and tell me, if he's going to change something. Then the anesthesiologist will come by. Hey, April, I'm going to change this epidural rate. So I am just an information gatherer that then I can convey to the patient or to the nurse or to a family member. So we do communicate and interface with the patient on those variables of each part of the surgical journey.
That's very cool. I mean, I could literally sit here and talk to you guys all. I really all day long. But one question that I think our listeners would love to know the answer to is that I want to implement enhanced recovery. I want to use a multi-modal pain management regimen, and I want to use, I don't know, IV acetaminophen, just plucking something out of the air that is sometimes considered to be a struggle. So how do I appeal to the pharmacy to say this would probably be a better, if it is or not, this may be a better choice for my patients? Because I mean, there are a lot of barriers that have been put up because financially that may not look sensible when you're looking at it in the silo. But if you're looking at it through a spectrum of care and a continuum of care, it may look differently. So what do we need to say to work collaboratively to make something like that work? And it doesn't have to be IV acetaminophen. It can be anything that you see in a pathway.
I think it depends on the patient population, too. So a lot of my practice is bariatric surgery. So in my world, it was very justifiable for me to say, hey, we have a lot of post-op nausea, vomiting. We're probably not even doing clear liquids until at least 6 hours post-op. This makes sense to do the IV Tylenol pre-op and post-op. Oral may not be feasible. That's sometimes a little bit harder of a sell in something like maybe orthopedic surgery, where they're hitting the floor on a general diet. But I think you've got to bring data to show, head-to-head data. Is the IV really better than the oral? And we have struggled to find that. I don't know, Rachel, if you have other opinions, but data is really the key, I think. Sometimes we struggle as a pharmacy of just people come to us and say, well, we want this. And we say, why? And they can't really show us why. So
it seems like enhanced recovery pathways, we don't necessarily, is there justification? I mean, have you found the justification for using some of these more expensive or different types of drugs?
It just, through the time with ERAS, I have realized that studying pain is very, very difficult because it's very subjective, and we have different modalities in which our control arms can change really the outcome, whether it was a PCA that the patient had free utilization of, or was it more controlled in which the RN had to give an IV push. So I think the water is very muddy out there. I do listen a lot to my nurses, and I know that they really felt they seen a difference whenever they administered IV acetaminophen when we had it on formulary. But at the same time, the data is not showing that clearly in the literature. So with that, since we are very data-driven, it's hard to justify it to your big pharmacy and therapeutics committee. So I think we just run into challenges whenever it comes to more expensive products that do not have the data there to support it, to really justify it, because a lot of the times we look at the number of morphine equivalents that it may have saved. It may have saved, 10 MMEs, but how does that really impact clinical outcomes? So just trying to tie it as much to clinical outcomes, then to value, and how did that impact my patient care? So really, I think, we have many things in our toolbox. We'd like more, but to treat analgesia, so I would, approach the patient and be like, these are the things that we can offer you. And try to, if IV acetaminophen isn't on formulary, just say, this is what we have, this is what we're going to do, develop that vision with the patient, and say, we will do everything to make your pain tolerable, and just go from there.
And wait for it to go off formulary. Or
off label. Off patent. So there's a lot of talk about creating pilot programs and things like that. Liz, have you done that in your practice?
So we have. I think that's made the case, a pilot or a proof of concept. For enhanced recovery in each of the elective surgeries. Our hospitals identified 48 elective surgeries, which is around 12,000 cases a year, that they want to deploy this. And some gather all of their faculty and go head on, and others prefer that pilot or proof of concept with one surgeon in order to demonstrate to the rest this is safe and effective for our population. So I say whatever approach you want to do, it really is up to that clinical group. They're the ones doing it every day, all day. So that interdisciplinary team. My job is to help them get the resources that we have on campus, connect them to the right clinical pharmacist and endocrinologist and nutritionist and all the resources that we have on campus, because they may not have the time or energy to coordinate that. Mm-hmm. So I help support those efforts, and then I let the team, drive their performance and projects, because again, they're in it every day doing it. And we've seen success with that so far in the 2 years that we've been a whole program. Enhanced Recovery has been at our hospital for much longer, but in silos. And now as a program, we're able to share best practices. I want to highlight one. We have our operations committee every month. This Tuesday, we had our local expert palliative care physician come and talk. And to talk about palliative care discussions around the periop setting, something that many of the team members really hadn't considered, but I had heard it last year at ACER brought up, and I thought this is, again, we have local experts here that we can share these practices and integrate into these. Really, I think it's a bundle of care, as we also participate in bundle payment, from the time to the decision of surgery to 30 days post-op. So really helping those teams be as successful as they can with the limitations or challenges they may have in their environment. So we're really proud. We have 18 pathways so far with 13 surgical teams, and we're looking forward to many more.
Phenomenal. That's awesome. Well, congratulations to you guys. Wonderful poster. It's fantastic. Can't wait to hear more and hopefully get you guys involved in some of these other conversations, because we need to collaborate more, and we need some good, strong voices, and you guys have them. That's good.
We would love that.
Thank you.
Thanks for having us.
Thank
Yeah.
you.
Well, Liz.
I just mentioned Rachel.
She did. Well, ladies, thank you so much.
Right.
And look forward to future conversations. So be sure to listen to Top Med Talk on your favorite podcatcher. Catch us on social media. We're going to be putting up pictures and some of the content we've gotten here from ACER. So keep on the lookout for that, and we will see you soon.
Top Med Talk.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.